LIMBER-104 is a study of a drug called Zilurgisertib, which is from Incyte Corporation and is a small molecule inhibitor of ACVR1, also known as ALK2. Now, in recent years in the field of myelofibrosis, a lot of excitement has built up around ACVR1 as a therapeutic target. What happens is when you block ACVR1, you reduce the production of hepcidin from the liver. And in doing so, you make iron more available for erythropoiesis and less of it getting sequestered in the reticuloendothelial system. So this enhanced availability of iron leads to improved hemoglobin. And this is a proven story in the sense that we've known this for Myelofibrosis for a number of years now. We recently saw this in the context of Prithviraj, that was about a year ago. And now Incyte has their own ACVR1 inhibitor, Zilurgisertib, which could be a nice combination partner for Ruxolitinib, which of course is the tried and tested sort of old workhorse in the field of myelofibrosis therapy, having been the cornerstone JAK inhibitor for over a decade now. So in this trial, the Zilurgisertib trial, we are treating anemic patients with myelofibrosis. Initially, the trial had two cohorts, treatment group A and treatment group B. Treatment group A was Zilurgisertib alone, and treatment group B is Zilurgisertib added in patients on a stable dose of Ruxolitinib. Treatment group A could have patients who were previously on Ruxolitinib or were not candidates for Ruxolitinib, but the drug is used alone in that group, whereas B is an add-on cohort. And now treatment group C is going to investigate the combination of Ruxolitinib and Zilurgisertib from the get-go, so in a frontline setting. So what has been presented thus far are results from treatment groups A and B. C is really too new at this point, and the drug is clearly active. Dose escalation is ongoing in both cohorts, and for example, 600 milligrams is currently being looked at, but the results that are out there are on up to 400 milligrams. And what we're seeing is anemia responses both to the monotherapy and in the combination setting with Ruxolitinib. Thus far in the results presented this year in patients who are not transfusion dependent, but it's very possible that with time we will see responses in transfusion-dependent patients as well, but not yet. We're also seeing proof of principle of the target engagement in the sense that hepcidin levels go down, which is what the drug is supposed to do. And so that is something that has been seen, for example, at the 200 dose in the combo setting and the 400 dose in the monotherapy setting. But that is probably just a function of where we are in the trial at this point. We'll probably see even more profound reductions as we go up on the dose. Like I said, dose escalation is ongoing.